Okay, thanks. I'm going to try to stay on time here. Uh, I spent my entire career kind of building and using electronic medical records, and then a couple of years ago, I was asked to come and start a Department of Population Health in a new medical school. The medical school was created by the taxpayers of Travis County, Texas, voting themselves a tax increase in the middle of a recession. And as a result, the dean comes in and says, we are going to do what we can to make this a model healthy city. And so population health is right at the center. For most of you know, population health has a lot of different definitions. You go around the room, everybody's got a different definition of population and health. And in many cases, you hear that term used within health systems, and it means patient cohort management, okay? We take the geographic perspective, kind of the governmental perspective, that we have a catchment area for which we take responsibility for health. And I come in this actually being a fraud, because I don't know anything about population health. I've always worked inside a health system. I was the chairman of the Department of Medicine in a large inner city health system. I practiced medicine within the system. I've never done anything outside those walls. And so one of the reasons I took the job was to make myself try to get upstream from sick care, which is what we deliver in health systems, to health care. And what I'm going to tell you now, I'm sure most of the people in the room know more than I do. This is what I've had to discover as I try to do my job of creating a population health program in the middle of a reasonably decent sized city. So I have no financial conflicts of interest. And this is not coming up on here for some reason. I'll run off of there. So I'm going to talk about what are the determinants of health and what are usable data on the social determinants, what to do when you don't have the data, and future needs and directions. So this is the amount of money that the OECD countries spend on health, at least back in 2014. And if you look over on the far right, that's the United States, and we spent about, at that time, 16% of our GDP, per capita GDP, on health care, okay, which is a third higher than the second highest countries, which were 12%, and almost double the average. And yet, if you look at the overall funding, we're a little bit above the median, because we spend half as much, only 9% of our GDP, on all other aspects of health, okay? And if you look at that green line, that's life expectancy. So we're paying the most for health care, we're not paying the most for health, but we're getting the least value. Because we're focusing on if you look at the other countries that are doing better, the dark blue bar is taller than the light blue bar. They're focusing more on health prevention, so health promotion and disease prevention than they are on sick care. So, what are the social determinants of health? Well, and this is a study that was done, a very nice study done by the University of Wisconsin Population Health, the Department of Population Health Sciences, called the county data matrix. And 10% of health outcomes. If health outcomes are the quality of life times the quantity of life times life expectancy, 10% are due to the physical environment, okay? And that are things like green space, housing, transit, air quality, et cetera. 20% are the $3 trillion we spend a year on healthcare, okay? And those are driven by the access of care and the quality of the care delivered. 30% are what our patients do. Things like smoking cessation, diet, exercise, sleep, doing what your mother told you, alcohol, drug use, and sexual activity, etc. And a whopping 40% are the social and economic factors, such as education and training. You can read those up there, hopefully. So where does the data come for those things? Well, for air quality, stuff like that, they come from, there are some available data, things like from the EPA and other, and NOAA, et cetera. There are people that measure things like pollen counts and things like that. There are housing and transit, there are transportation databases within cities, green space, you got maps, all right, things like that. For healthcare, it all comes from EHRs, right? We at Regent and in other places, to help manage populations, we create these things called health information exchanges. In reality, they're EMR exchanges. It's just data from EMRs. They don't have any data to get you upstream from there. For these behavioral things, actually the only place these information really come from reliably are your patients. And we don't reliably capture them. When we do, we don't reliably put them in places where they're easily retrievable. not without really good note taking and NLP programs. And then, so this guy is frozen. Let's hope that doesn't continue. Okay.
I can escape and down.
It's doing stuff. They're separate from up here, so there's some disconnect between the two.
Oh, sorry.
So,
Yep.
okay. Hopefully that'll work. Okay.
Yep.
And then for things like education and training, they have to come to the training, but there's also information from the school systems, employment and housing. Again, there may be some information in city county databases. You can look at those things there, but there may not be a lot of reliable places to get this information for us to make our impact these things. So there's a system, and here's some examples. So there's a system in Indiana called SAVI. That's called Social Attributes and Vulnerability Indicators. And an organization at the university called the Polis Center has put together this system and updates it on a fairly regular basis that just brings in existing data. And so the left column are the kinds of data. So you have census data here, and then the third column is the level of granularity. So things like BG is block group, CO is county, TR is census tract, township and school corporation. Okay. And so they have various degrees of granularity that may or may not be useful, especially if you can combine them with things that are in EHRs. If you have addresses, you can geocode those and you know where patients live. More census data. There's information from the Indiana State Department of Education. And if you're interested, savvy.org, you can look all this stuff up. So I don't want to go this. Home Mortgage Disclosure Act and housing. I spent more time in the last 9 months talking about housing than anything else. Who knew? But if you don't have housing, you don't have health, period. Don't bother trying to get anything else happen if somebody doesn't have stable housing. And most of the homeless people are not living on the street. Most of the homeless people are single mothers with kids living in cars, living in people's basements, and just not having a stable home. And if you believe in adverse childhood events, we're really creating a ton of these because we don't have housing. And so if you care about population health, you care about building houses. So HUD databases, et cetera. Indiana State Department of Health, the state health departments, and I was actually introduced to this by Roland back 20 years ago when he worked for the Indiana State Health Department. They have a ton of data they collect and are almost never used. And so use them. And so, but they have to be in a usable place in a usable format. And then there's family and social services, birth defect data, communicable diseases, et cetera. And I don't think I have it in here, but they also have EPA data. Turns out in Austin, there's this organization called Children's Optimal Health that put together data to try to do the same type of thing within Austin, although they had no health information exchange to be able to bring in any healthcare data. But they have information from business and industry, from crime and safety, from the Texas Educational Agency. And unfortunately, most of these are at the county level. This is really interesting data. So they get all these data very granular by school within the school system. And so if you know where the catchment areas are of the schools, you can begin looking at things that have patterns, where there happen to be. And in Austin is the most segregated, is the third most segregated city in the country. And so there are enclaves where these things actually group, where if you want to share activities, focus where they're needed. So these are just the different databases. They've got information, GIS data from the city of Austin, from the transportation system, et cetera. So some of these data exist and are usable, but maybe not very useful, and also not paid for. So this system hasn't been updated in 4 years. And as you might, Austin is also one of the fastest growing cities in the country. It's also one of the fastest shrinking cities in the country, which means they're outgassing people. It's the diaspora of the poor people going out to the surrounding county and counties. And therefore, these data aren't reliable after 4 years. But there's no way of funding they're being updated because people aren't extracting value from them. So part of this is, and hopefully somebody can talk about it, is how can the available data be made self-sustaining? How can we extract the value, and the people who are getting value are willing to pay for it? And I don't know the answer to that question yet. So the available data on social determinants of health, it's collected by various agencies with different protocols, and it's really hard to use because it's at different levels of granularity geographically. They're updated irregularly, and they're ecologic, which is okay for planning and advocacy and okay for program development, not very okay for actually taking care of people. But here's an example of how they're useful. This was a study done in Indiana that took the EPA soil sampling for lead, which was in the SAVI database, and then looked for lead levels within the Indiana Network for Patient Care, and saw actually some clustering. You know, some looked like there was some that in the areas where there was more soil lead, there seemed to be more people being diagnosed, kids being diagnosed as having elevated lead levels. And so that got them enough information to get funding to go out and do a prospective study where they actually took the, I'm sorry you can't see this real well, but it's a heat map, and the lower left corner, that little panhandle down there, is a Superfund site. This is in Indianapolis. And the darker colors in the background are the soil density of lead, and the dots are the number of people in specific block areas who have kids who have elevated lead levels, and they're highly correlated. So these kids are getting lead from the soil, and so it just means you need soil abatement if you want to be able to prevent the downstream effects of elevated lead levels, especially in these areas. And as you might guess, this is a poor area of Indianapolis. I want to read the conclusion in the abstract. It says, countywide, the biggest predictor of elevated lead levels is the location within the urban care, within the urban core. Sorry, this is not coming up on my screen here, so I can't see it. Variation in soil pH and blood levels on the community level is high and not predicted by housing stock or income, which means it ain't eating paint. This is actually coming from the soil. So I'm sure there's not telling any of the public health guys in the audience anything, and I appreciate it. It tells me a lot because I'm ignorant about these things. But what if you do if you don't have the ecologic data? Or what if you do if the ecologic data aren't good enough? And I'll argue that you have to go out and collect it. So one way is just go door to door and begin assessing the individual health. First of all, a census, who actually lives there, because the census isn't necessarily right, especially in immigrant communities and where there are a large number of people who are undocumented. And then you can look at household barriers for needs and meeting needs and preferences, priorities for the people of those households that have their needs met. An example of this was a program that I was involved with in Kenya, a large program called AMPATH, and I'm not going to go into that. But they had a thing called FLITR, Find, Link, Treat, and Retain and Care. If they wanted to get initially focused on HIV, if you're going to break the back of the HIV epidemic, you can't wait for people to come in sick because they've been passing the virus on for a decade before they got symptomatic. And so they went to upstream and began doing in-home testing for HIV and eventually other things like diabetes and hypertension. And this is a picture of one of the guys going into a household and using Android phones that were developed by folks from Regan Street, collecting information directly linked to our electronic medical records, open MRS system in Kenya. And this is somebody from June of this past year being tested for HIV in the home. And we'll give a result to the person in the home. Okay, so this is the 1 millionth person who was interviewed in this program in 2014. And as of now, they've interviewed 2 million, they've knocked on the doors of 2 million people and gotten 98% entry and complete capture of information. So the question was, if we can do that in Kenya, can we do it in Austin? And the answer is, I don't know. So we're trying to find out. So we're doing this feasibility study that looks at using focus groups on how to get entry. We're trying to figure out what the hell you can ask in a very short period of time. And we're promoting on screening questions so you can go back into a deep dive. We're programming this on mobile devices, and we're going to hire and train community health workers, not only do the assessments, but then stay in those neighborhoods and help meet the needs. And we're in the process of doing trial surveys. Now, the reason they're going to stay in the community to meet the needs is going to be part of this thing called the community-centered health home model, in which is focused on FQHCs being a anchor institution in low-income neighborhoods. You establish relationship with community organizations who actually meet the social determinants of health. And then you assess the local and structural needs by using household assessments and other information available. You take responsibility for meeting both healthcare and community health needs, and using the community health workers as a way of doing that. and getting paid for it because the county system for tax system for caring for the indigent is becoming capitated this year. So the bottom line, see, you don't flash a sign anymore. I'm almost done. Okay, the bottom line is that please don't freeze on me again. There is no bottom line. Bottom line is this is all really a work in progress. Anyway, so the bottom line is that use available data. I mean, first of all, you can't make it better if you don't measure it. Okay, use available data when you can. That's hard. So hopefully establish information systems that make it better. So we're creating an HIE in Texas that includes not only data from EHRs, but includes data from Children's Optimal Health and other places we can get that information in a single database where they're already linked. So this, like, it took 6 months to be able to get this lead database in Indianapolis done. So be willing to use the able to use the available data. Be willing to go out and capture your own data. All right, don't just look for your keys under the lamppost, but go out and look for what's important, because not everything is important is already being measured by somebody else for some other reason. You have a different reason to do it yourself. And for that, we'll need tools, the types of tools that hopefully you all in the audience will be developing for us. Thanks.